We live? Are we live now, Emily? Good afternoon. My name is Dr. Shanice Martin Stansel-Ill, and I am the Nursing Director for Diversity, Equity, and Inclusion. I am also an Assistant Professor of Clinical Nursing for the University of Rochester School of Nursing and an advisor for the Professional Nursing Cultural Inclusion Council.
Hello, my name is Dr. Gilda Johnson, and I am the Chief Resident for the Internal Medicine and Pediatrics Residency Program and the President of the Association of Minority Residents and Fellows, better known as AMRF. On behalf of AMRF and the Office of Equity and Inclusion here at the University of Rochester Medical Center, we would like to say welcome and happy Black History Month.
Dr. Johnson and I will be your MCs for today's session. Today's speakers is the first in our 21-day Racial Equity Challenge themed Black Excellence, Living Healthy Matters. On Friday, February 17th, we will hear from Beatrice LeBron, Vice President of the Rochester Board of Education. And on Friday, February 24th, we will close with Dr. Angel Palermo, the Chief Diversity Officer in Education and Research for the ICANN School of Medicine and Dentistry at Mount Sinai. On the Monday following each session from noon until 1, we will host a debrief, and more information can be found on urmccelebrates.com.
Today, we have the privilege of hearing from Dr. Twyla Dillian, Executive Director of Health Connect One. Dr. Dillian has had 10 plus years of experience in the nonprofit sector, spanning philanthropy, Medicaid reform, maternal child health, data analytics, and academia. In her prior work, she has investigated the role of maternal personality in breastfeeding, led a data analytics team in Medicaid reform, served as program officer for maternal child health programs, and led a patient-centered outcomes research institute, PCORI, project at the Healthy Baby Network in collaboration with Black moms to identify contributors to and strategies for Black maternal mortality and morbidity. She is committed to birth justice and first food equity in Black, Brown, and Indigenous communities, focusing on community building and workforce development.
As a Black women leader, Dr. Dillian is committed to promoting, cultivating, collaborating with, and embodying leadership reflective of the Black, Brown, and Indigenous communities often served by nonprofit sectors. She received her PhD in Health Services Research, Policy, and Outcomes at the University of Rochester School of Medicine and Dentistry, and her MBA from St. John Fisher College. I will now hand it over to Dr. Dillian.
Thank you. Let me get the screen up. All right. Everyone can see my screen, correct? A thumbs up is adequate. Cool. All right. So as everybody knows, good afternoon. I am Dr. Twyla Dillian, Executive Director of Health Connect One. We're a national nonprofit focused on birth justice for Black, Latinx, and Indigenous communities. I'm happy to share with you about our work today. So first, how I got here, right? So how did I get to this role? I'm gonna go super personal at the beginning and the end. This was a picture of me at my first birth with my oldest child, who's now 24. I had her at 18. My birth experience was somewhat traumatic, largely due to the fact that I felt a lot of bias in the room anytime I was in a clinical setting, due to my age and my race. I never was a recipient of Medicaid. I wasn't lower income. I had a lot of support, even though I was a single mother and I was young. My grandmother, who was a midwife and was a huge influence on me, came from Jamaica and lived with me. So she was trained as a midwife in Britain. So I didn't have to call them midwife. She was in my house day in, day out. And it was great to have her there. Oh,
Dr. Dillian, your slides are not moving forward, just a heads up.
Sorry. Oh, that's not good. Hang on. So y'all are missing the whole thing and I'm being recorded. Hang on. Let's see. You see it now? Okay, yeah, you must have to look at it while I'm doing it. All right, we'll back up a little bit. So that's me when I had my first baby. That's me, and I had her at 18. As I said before, the experience was somewhat traumatizing for me based on my race, my age, and being single. I had a midwife living with me. My grandmother, as I said, came up from Jamaica, As I said before, my bad joke, didn't have to call her. She was right there in the next room throughout most of my pregnancy. It was challenging, being on my own, but I did have all the resources that I needed, with the exception of, a lot that comes with maturity and having had other kids. So it was all pretty new. My birth experience, a lot of things were pushed on me. I wanted to have a natural experience. I didn't know anything about doulas, even though the organization that I now run was actually forming in Chicago at the exact same time I was having my little girls. They were starting their doula work then. The providers, the hospital really tried to push a C-section on me because I was in labor for quite a while and I was really uncomfortable. I had all sorts of interventions, including an episiotomy. It was a lot for me to take on. So this was one of the reasons that I was motivated to move forward in my education and in my career and pursue this really important birth justice work that I do now. There's a happy picture at the end. You'll see that later. All right, so together with community-based organizations, public partners, MCOs, health systems, and perinatal health advocates, Health Connect One trains community health workers, including doulas and breastfeeding peer counselors. We connect community-based initiatives and mobilize diverse stakeholders to build policies and programs that improve birth equity. So for those of you who aren't familiar with birth equity, it is defined as the assurance of the conditions of optimal births for all people with a willingness to address racial and social inequalities in a sustained effort. Very, very core to our work and the work of many other organizations like ours. The work that we do really is focused on 5 essential components. So we employ folks from the communities that we serve. We extend and intensify the role of a community birth worker. We collaborate with community stakeholders. We facilitate experiential learning, and we value the community birth workers' work with salary. Those 5 things have been essentials for Health Connect One since they started in the 80s and since doula programming began in the 90s. We do this work, as I said before, with several different partners. The dots show the different places where we're working currently, and they are rapidly changing. For any of you who know about the doula landscape in the United States, there's a huge uptick in policies that are including doula reimbursement through Medicaid and private insurance, which is increasing the need for trainings because there aren't enough doulas to serve those who actually need them. So that's something that we're really right at the forefront of throughout the country. So a little bit about our agenda, since you know a bit about Health Connect One now. We're going to talk about the landscape of the birthing workforce, highlight some existing gaps, talk about some funding sources across the birthing workforce, and I'm going to add a little bit of information about a project that's happening in Rochester right now. Some of this stuff you might know already. I promise not to read from the slides. I may go slightly off script because I tend to do that, but we're going to jump right in. So some definitions, and I won't read through all of them. These are the things that the roles that we actually are really involved in training. Some of the roles we're really involved in training. Perinatal community health worker, that role is a broader role. It's not necessarily someone who provides support as a doula or in labor, but can really support folks in their community in a variety of capacities, including advocacy, social work, etc. Community-based doula is a role that Health Connect One actually helped to coin. The organization developed the first formalized training model in the United States for community-based doula. And this is different than other doulas primarily because this person is from the community where they're serving. They share culture, they share language, they know what's happening on their block, right? They're really much more boots on the ground than other doulas who may be coming in from neighboring communities. They provide, as I said, that culturally congruent support. A doula provides pregnancy and childbirth education, comfort measures. They are non-clinical providers. That's a doula across the board are non-clinical providers. There's several subspecialties for doula. Again, a trained professional, all the things listed there, I won't read through them, but it's important to know the difference. I'd love for, if you don't remember anything, when you leave this session, knowing the difference between a doula and a community-based doula, right? So a doula is the overarching definition. That could be anyone who's trained in that pregnancy, education, comfort measures, advocacy, etc. A community-based doula is rooted in the community they serve. So like we recruit from the community, right? People who are already there, speak the language, share the culture, know what's going on the block, right? Those are community-based doulas. So it's important to know that difference. Direct entry midwife, some of you are probably familiar. This isn't someone who's gone through a nursing school to be trained as a midwife. They are trained directly. So they go through a midwifery program. You've probably heard a bit about folks who've gone through that pathway. There's been many issues as far as legislation and policy around folks who've gone through this direct entry midwife pathway. Lactation and breastfeeding peer counselor. This is another one that Health Connect One was really important in developing. Health Connect One helped to support the breastfeeding peer counselor program for WIC. So that model was designed in partnership with Health Connect One. These are folks similarly to the doulas that are from the community, right? They haven't gone through lengthy education, but they've had a successful experience with breastfeeding, right? And they're able to be a peer to others who are going to be going through that process as well. Also, very important that these folks are culturally congruent. They speak the same language. They're from the same community as those they serve. Again, we recruit from the community. Home visitors. So McVie programs support several different home visitation models. I think you're all pretty familiar, or maybe not all of you, but some of you are probably familiar with nurse family partnership, parents as teachers, building healthy children, which is actually at the U of R. So these different models, and there's several other models, these different models are not the same as a doula program because they're providing a different kind of support. And each of the models have different ways that they are able to engage and support families. So these are some of the different community birthing workforce definitions. What does that look like actually in practice, and where do folks show up? If you look at this, just to orient yourselves, it's got the entire perinatal period basically mapped here and showing kind of where you'll see different people, how those folks are covered, where they're rooted. So people who are health system rooted, you can see that they're showing up over here. So your nurse midwife, OBGYN, and again, within there are several subspecialties. During labor and delivery, you get a different crew, right? So you've got people who are, again, nurses, many subspecialties, anesthetists and anesthesiologists, neonatologists, pediatricians. These are where you're going to have some of those different clinical folks showing up. And then over here, again, you've got your lactation, breastfeeding peer counselor, certified lactation consultant, showing up usually third trimester, all the way through. Some will be present through extended postpartum, providing that support around lactation. And then here, this is intentional. Any of these folks who are community-based, they're going to be showing up from conception all the way through to extended postpartum, right? So these are folks who are really, honestly, the only group that is consistent throughout that entire time frame. And that's incredibly important because that consistency is something that can really change outcomes for folks who are Black, Latinx, and Indigenous. And they're more likely to, as you know, especially the Black and Indigenous community, to have negative outcomes associated with birth. And I'm not going to spend a ton of time talking about that because I want this to be more focused on solution, right? So really looking and seeing that all of these different folks can be present, can provide advocacy, can provide education, can provide support and referrals to social work, to mental health supports, to supports that are going to help reduce the impact of the social determinants of health. Unfortunately, culturally congruent community-based support is not always available to those who need it. Usually this is based on inadequate funding, right? The funding for these different categories varies dramatically from state to state, city to city, neighborhood to neighborhood. You're going to have a wide range of availability, and that makes it difficult for community members to actually get what they need throughout this birthing experience. Another important point, which I'm going to talk about, is caregiver burnout. Specifically around doulas, the average time a doula continues in their role is 3 to 7 years, right? They're going to burn out. Most are experiencing some burnout by 3 years, particularly those that are based in community, because they're supporting people through things that they may not necessarily have adequate solutions for, right? Social ills, things that are happening in communities. I mean, you can look at our own community and see all of the different challenges we've faced with community violence recently. A doula can't support that, but still needs to be there to support the birthing people with whom they work. I'm sure you've all learned about the importance of providing culturally congruent care, but I'm going to lift it again. research has shown that Black clinicians attending births and serving infants reduced Black maternal and neonate mortality. Community-based doulas often serve as this cultural bridge between the birthing family and the healthcare team. In many instances, if there are linguistic barriers, they're also helping to facilitate communication. Breastfeeding peer counselors with similar cultural roots as their clients are able to build trust as peers, serve as an empathetic role model, and share strategies for overcoming breastfeeding difficulties. These are really incredible and incredibly important roles. And oftentimes there's not enough resources, financial resources, to actually have these folks present. These folks actually improve outcomes of clinical systems without recognition of the role that they're actually serving, because they're doing it within their communities in support of their communities and are not necessarily affiliated with hospital systems. So investing in this culturally congruent care for community-based birth workers will improve economic mobility for the people who are often living in the same communities as those they serve. So I'm going to say that one more time. A lot of the folks who we're working with and training, and other doula training organizations are doing the same, them being trained to work as doulas when there's adequate funding will improve economic mobility for them. The communities that we focus on are underinvested. There's not enough money in those communities. Being able to train someone and give them this workforce development can change their trajectory and improve what's going on within their community as well. So there's two roles in this training that we provide. It's important to point out, and this is something that if you haven't heard about it before, you will hear about it again. It's vitally important that doulas receive fair pay, right? The reimbursement rates don't account for many of the costs associated with working as a doula or administrating a doula program. Things like billing assistance, right? It's one thing to say that doulas can be reimbursed by Medicaid. It's another thing to say that they'll receive support in doing so. In some of the states where we're working, we're recognizing that the expectation is that doulas will enroll in Medicaid just like clinicians do to be reimbursed. And that's not the same process. These folks don't, in many instances, have to go through the same types of accreditation just because they're non-clinical. But the United States and most states that we're working with haven't figured out an easier way for community partners to enroll and be reimbursed by Medicaid. Another thing that's vitally important is that folks receive supervision and support, right? It's not just the financial element of it, it's the ability to have someone to talk to around the work that you're doing, having, supervision that is reflective, folks who are going to be able to support doulas when they don't quite know who to turn to. There's a ton of vicarious trauma that happens with folks who are providing this type of support. So it's really important that the pay situation is remedied, and that's something that I'm going to talk about a little bit with some bills that are being put forth, and that doulas are receiving support from people who understand the type of work that they're doing. Since arriving at Health Connect One, one of the things that we've developed and have been working on is identifying a way to get to sustainable funding for doula work. The process right now really is more around money that is coming from philanthropy, which is not promised. And we identify as well that as Medicaid reimbursement starts to take hold in different places, that philanthropic funding is going to fall away, right? Because if you can receive the money through Medicaid, why would philanthropy still be paying it? The challenge with that is that in most instances, the Medicaid reimbursement is inadequate to actually cover the costs associated with being a doula. So I can give you an example. Anyone who's works in OB gets it. A birth can last a really, really long time, particularly a first birth, right? And in most instances, the doula is present for that entire time. There's no way that a reimbursement rate for an entire episode of care for a birthing person at $1,000 will cover several home visits, constant contact, 72 hours spent supporting that birthing person or more, supporting that birthing person, and then the postpartum support, right? So even at the bare minimum of, offering just what, like maybe one prenatal visit, which is not ideal, being there for the birth and then showing up postpartum once, that's still not enough if the birth is particularly long. So, and that's not an ideal scenario to have one pre, one post. But in any case, the amount that's being proposed across the country and what will likely influence reimbursement in New York State is inadequate to cover the associated costs. And if philanthropic dollars fall away, it'll be very difficult to retain any doula workforce that would be willing to provide support for folks who are where the payment's going to be reimbursed via Medicaid. If the money's not there, we'll lose so many people in the workforce. So we have to really be thoughtful about that. One of the reasons why we are doing a lot of advocacy in that space and making sure that people understand what it actually takes to elicit a positive outcome, right? How much effort is required. We're collaborating with doula organizations across the nation. It's called our Doula Data Project, where we're collecting information around how much time, how much effort is required to have these positive outcomes or have any outcomes, to be frank, and kind of seeing how that matches up across the country and using that information to really pressure different state governments to have better reimbursement rates. There's a high demand for doulas. We're providing training throughout the country to increase the doula workforce. But again, if the money's not there to pay people, it really feels like we're training people on a bridge to nowhere, right? So that's another reason that we advocate to get that support for doulas. Some bills that are currently being discussed in New York State. The first one, S362, is to include doulas as medical service providers for Medicaid recipients. And the other one is New York State Community Doula Directory. It's important that both of these things occur. Both are constantly in revision. There's going to be a testimony provided. I'm going to attend actually in New York around doulas in March. So that this is really heating up and we're excited to see what comes next. But the reimbursement rates, again, we know kind of how this goes, having worked in other states. They're not going to start out right, but it does provide an opportunity to generate more data, more information, and be able to move forward from wherever we start. And as I keep talking about doula reimbursement, here are the different states that actually have it. So 7 states are currently doing reimbursement. The most recent one is Rhode Island. They actually came in with a pretty decent rate. I think it's around $2,000. And several other states are in negotiations to implement doula coverage. California is one that's very interesting. We're having a lot of discussions with them and supporting their work with the goal of really being a lot more inclusive in the planning than some of the other states have been. We're also facilitating the New Jersey statewide Doula Learning Collaborative, which is an opportunity to provide training and billing education for doulas across the state of New Jersey. And that's really exciting work as well. But this is kind of what it looks like right now. I'm fairly certain this is going to continue to increase. And in some instances, managed care organizations recognize the value and are reimbursing ahead of state mandates to do so. So I'm going to jump to Rochester now, because that's where we are. I'm here too. So the Rochester Black Doula Hub, very, very exciting project. They had a doula program at Healthy Baby Network, which is a partner that we're working with on this project. And there definitely was a need to do more expansion. So they were able to attract some money from the Finger Lakes Performing Provider System to really solidify the work that's being done in our community. It was initially a 2-year project. Some of it's kind of stretching over a little bit. Health Connect One provided the training. We provided technical assistance and project management to this work. One thing that's been really incredible about this work, and we also have a partner in, the rural community, Finger Lakes Community Health. At Healthy Baby Network, we're focusing on the Black community, and then Finger Lakes Community Health is focusing on Latinx community with a heavy emphasis on folks who are migrant workers. So both really, really exciting work. So one thing that's been vitally important for this project is collaboration with the hospital systems. If you don't partner right up front, it's very difficult for the doulas to gain entry and access to supporting birthing people and doing it in a way that is, in the way that birthing people want to be supported, right? Not having a ton of barriers to being there throughout the entire birthing process. So we've had many conversations, community kickoff and discussions with Rochester Regional and the University of Rochester around how this could work best. Initially, there was hesitancy because it's new, right? And having additional people in the birthing space can sometimes feel complicated for clinicians. But I can proudly state that where we are right now, I think it's at the University of Rochester. We have the nurses are so happy to have the doulas there. They're baking them cookies. So it's definitely taken a very positive turn. And it's just, I can't imagine not having this kind of support in our community at this point. So it's gone really, really well. And I'm excited to see where it goes next. Some updates. We have 177 families referred. There's a 96.4% successful breastfeeding initiation rate. And the C-section rate is lower than the New York State average. As you can see there, it's 22.8%. And then the patient satisfaction rate is pretty high. It's 9.5 out of 10. So things are going quite well with this project. I'm hopeful that we'll have even more updates for the University of Rochester and Rochester Regional as the project continues. We're working with different local folks to figure out other ways to sustain some funding when the FLIPS funding ends. Because it will come to an end pretty soon. So we're working on that still. So I'm going to shift a little bit. I'm used to being interrupted. I know I'm not supposed to be. I'm going to shift a little bit to talk some about the workforce, right? The people that we're training, the people we're supporting. There's been several different conversations with funders that we've worked with in the past around competency and capacity building and things of that nature. And really, when we lean into that too heavily, we take away from what's already there, right? These communities know what they need, right? They're closest to the issues, as we know. And it's not helpful to say they need to be quote unquote fixed or the capacity needs to be built. They need to be trained, right? As doulas and community-based birth workers, but they don't necessarily need anything to be dramatically shifted. We don't want to take away some of what the value is that they bring to the communities they serve, the realness, if you will, the fact that they can relate to the birthing people in their community, that they know what happened in that community. They know some of the negative things that have unfortunately occurred and ways in which the community could be better supported or served. We don't want to take that away. So we're not necessarily developing them in any ways other than skill. We want them to retain their authenticity. We want to make sure that we're not imposing anything on them. We want to make sure that we're not comparing them to a traditional medical system, because that is not what they are. This is a complementary support. We want to recognize the strengths and the navigational capital that they already have. The community birth worker field has existed informally for a very long time, right? People have always supported those in their community who are bringing new life into the world, not necessarily in a way where it had a label, but that's always happened. And any attempts that I've seen to integrate, right, community-based birth workers into clinical settings always results in some sort of trade-off, right? So if they're in an environment that's much more bureaucratic than obviously the work that they've been doing, out in the community where they don't have some of that autonomy, it can take away some of the very important advocacy work they do, right? I'm sure you've all heard different horror stories of Black and brown birthing people having their voices dampened and then suffering really terrible consequences, talking about some pain they're feeling or something's just not right, and then not being able to be heard. That's really troubling. And advocacy from the doulas could look different if they're also functioning in an environment where they have to account to folks other than the communities they serve. So it's very important to point that out. It's important for us to build with community and not extract from community and drop it somewhere else. So I think I hammered on about that for long enough. I'm really passionate about that part. All right, so the last part before I go into some key takeaways and kind of tell you about where we are now and where we're going is caring for folks who are doing this work. So I mentioned before that there's a lot of vicarious trauma that is experienced by community-based birth workers. And mentioned that it's important for folks to have a livable wage, right? All of the things that we see underneath the water, right? Again, you've seen these scenarios before, this tip of the iceberg. All of the things that we see beneath the water are all things that doulas are facing, right? Community birth workers are facing. Many of these things are the same things that the people they're supporting are facing, right? And that makes it very difficult to adequately provide support if they don't get what they need, if they don't have that reflective supervision, if they don't have fair pay, right? Those things are both important. I saw a funny post on social media the other day. It wasn't funny, but it was interesting. It said that you get a salary raise once a year, and the culture in your organization is much more important because that's something you experience every day. I argue you should have both. right? You should be paid fairly, and you should be in an environment where you're comfortable showing up to work. People who take on the role of community-based birth worker, they become not necessarily hardened, but they know that it's a part of their job to experience some tense hospital interactions. That absolutely happens. For them to have unstable funding, that's something that I've been talking about since I started discussing this with you guys, and some of the exact same issues, right, that community members face, because again, they are from the same community. A lot of this is all rooted in racism that has existed in their communities for a very long time, and we know is baked into all of the systems that they're going to be interacting with, and that those they support are going to be interacting with. So caring for folks who are in this space looks like a lot of things. It looks like ensuring that they have access to mental health support. It looks like making sure, again, that they're paid fairly. I'll say that over and over. Making sure that their interactions with the hospital systems are able to happen in a way that is bidirectionally respectful, right? There's no need for that to be tense. That's something that Health Connect One and Healthy Baby Network have worked really hard at, to make sure that those relationships and the processes are straightforward. If we're talking about workforce development and economic mobility, a lot of the things that folks are facing here, some of these things, maybe they're able to circumnavigate because now they have better income, right? There's a lot of different pieces to this puzzle. There's a lot of reasons and rationales behind us providing this training and partnering and collaborating with communities to ensure better birth outcomes. So I'm going to jump to key takeaways, and then I'm going to tell you a wonderful story. So key takeaways: community-based supports are available from conception through an extended postpartum period, right? That was that slide that I shared earlier. This is the only type of support that birthing people can have from conception all the way through to extended postpartum. In fact, there are communities where doulas offer support to folks who are experiencing an abortion or folks who've had a miscarriage. There's a wide range of specialties that doulas have and the support that they provide. Birth workers, y'all heard me say this before, right? Birth workers deserve to be fairly and equitably compensated for their work with birthing families. A blended funding approach, including public and private funding, will ensure short and long-term sustainability of the birth worker workforce. Sustainability and fair pay are critical to support ongoing quality community-based care that advances maternal child health. So if you don't remember anything else, remember that doulas need better funding and that community-based supports are available for the longest period of time, right? So from conception all the way through extended postpartum with variation by program. So the happy story. The happy story. I have a lot of kids, y'all. Not a lot. I have 4. I think on average now people have 1.7. It's gone down, right? I think COVID had something to do with that, but it's still, less than I have at my house. So the first slide was my eldest, who's 24. She's a whole adult, she lives on her own. This slide has some of my favorite people in it. So Tracy Weber, who works at U of R, so my midwife, who I adore, my favorite people in the world, and my doula, Nella, who got there a little late for the birth, but I still love her. She was there for my second to last birth. And then Lily, the little human in my arms, and the little human on the right. That's what she looks like now on the right. My final birth story, the cherry on top, I will never do this again. That experience was so dramatically different from my first one. And I have 2 kids in the middle, and with each birth, right, it just became better because I learned more and I advocated for myself better. So all of the things that I'm saying that are important for birthing people throughout the community, I'm a walking story for that, testimony, if you will, because I've experienced that myself. My second birth, my son, have been advanced maternal age for a while. I almost said geriatric. I hate that term. Advanced maternal age for a while. And with each of them, there weren't necessarily complications, little minor things here and there. But with this last one, I was definitely the oldest because she's recent. And it was a scary time. And I had people who looked like me, and I had people who understood my experience. The more money you make as a Black woman, the more education you have as a Black woman, the more at risk you are of dying when you have a baby. It's not what people expect, right? affluent Black women are at more risk of dying during childbirth than low-income white women, right? So that doesn't protect you. Education, income does not protect you. So I was scared, y'all, really scared when I was having this baby. And I knew what I needed to do. I had a support team that is exactly what we describe and explain and advocate for those that we serve. And I had a party in my room after I had her. Tracy was not on shift, U of R. But I had a party in my room. I felt supported. Other doulas who I knew who were there, they came and checked on me. And I was able to feel free and confident and comfortable in my motherhood. I had no interventions other than the induction because I'm older. And she came out fast. And I just felt so strong, right? I've never felt so strong. And I also knew I was done. So it was a great cherry on top to my birthing experience. And it's something that I believe every birthing person should have. That is birth justice, right? To have the experience that you want, to have the experience where you feel comfortable, where you don't feel like someone is forcing something on you. I will share this as well, that in that birth experience, I did not see any Black labor and delivery nurses. I did have a Black nurse support me postpartum, but there's really a lot of room for increasing diversity in the workforce, right? People who train as doulas, I love seeing this when folks who train as doulas, they have a great experience in hospital systems and they say, you know what, I would like to work in a hospital. Like there are many that we've worked with who've gone on to continue their education. But there definitely is a gap there. There's a need to improve the diversity and to recruit from our community, right? To recruit from our community so that we have people who are based in the community who are getting this education and are able to provide support to folks in a variety of capacities, right? It's vitally important. So yeah, that's Lily. Lily's incredible. I'm glad that I'm done doing this birthing process. And it was the best way to end that. I want to make sure that y'all understand kind of how you can get involved with some of the work that we're doing at Health Connect One. And we really encourage people to get involved. The organization has grown dramatically since I've arrived there. We're growing our associate board, we're growing our board, we're having a conference, and I didn't include that information here, but I'm happy to share it. The conference is called Birth and Beyond, and it's going to be focused on folks who are doing work around birth equity and birth justice, whether that's advocacy or research. And we'd love to have, if we don't have one person from the University of Rochester, where I've graduated twice, presenting at that conference, I have failed. So I will make sure that we get that information out to folks over at U of R, but really having an opportunity to talk about the great work that's happening. That's something else that we're working on. And we're always looking for people to be on the research advisory board as well. So we have a research advisory board that didn't exist prior to my arrival. That research advisory board is comprised of Black, Latinx, and Indigenous women researchers who are supporting the work that we're doing and getting involved in different research projects alongside us as well. So that's been pretty incredible. And then I'll show my last slide. I don't know if I'm allowed to open up for questions. But my last slide includes our website. It also includes Instagram and a donate button, because as I said at the beginning, we're a nonprofit. So if you feel compelled, please jump on there and donate. My email address is there also. I'm happy to connect with anyone who would like to touch base after this presentation, and I will pause there.
All right. Please join me in thanking Dr. Dillion for her amazing talk. We would now like to open up the Q&A portion of our time together. So if you could please put questions in the chat, and I already see that there are some coming through.
All right, the first question we have is, for those of us who are not clinicians or not involved directly in OBGYN care, how do you suggest we introduce these conversations and try to incorporate doulas into community care for patients thinking about pregnancies or are currently pregnant?
That's a great question. So one way to do that, I know that throughout the community, we've shared RAT cards that provide a description of what a doula is and the kind of support that doulas provide. If you don't have any where you're currently working, I am more than happy to get you some. It provides a description of what a doula can do, a place where they can actually get access to a doula. So that doula hub that I described, that's based in Rochester, all of that information is in that RAT card. If you need more than that, I'm happy to connect, and you have my contact information. We can figure it out. We provide technical assistance in a number of ways, and we're still actively working in Rochester. We still have, vested interest here, and we'll always have a vested interest here because I'm here. But we're happy to connect with you and provide you with some of that information. If you need guidance on how to share it, things like that, we can definitely work through that with you too.
Thank you. The second question is similar to that one. It says, how does one go about finding a doula that can provide this type of culturally congruent care? Is there like a base of people?
Yeah, so this one, I'd say the best thing to do would be to connect with Healthy Baby Network if you're based in Rochester. Right now, the group that they're working with most is Black birthing people. But there's definitely room for expansion throughout the community because we do have a number of groups that could use additional support. I see a question further on down around linguistic differences as well. So yeah, I'm definitely going to encourage you to connect them with Healthy Baby Network. And I can provide that information as well after the talk. If there are folks that are based in the rural communities and are Spanish speaking, that would be Finger Lakes Community Health. And my belief or my expectation is as this work continues, we'll have groups that can work with different communities, right? Because we need to make sure we're supporting the diversity that exists in our community.
The next question is, can you share information about this important work in the refugee community and the deaf community, and particularly Arab speaking?
Great question. So because this is pretty new in the Rochester area, that is an area that we need to grow in. I think I could envision, it's coming to my head now because this came up, envision some collaboration with RIT. I think that's something that I'm going to explore as soon as I'm done talking here. That's something that could be really good. Within the Arab speaking community, we don't necessarily have a foothold there yet, but I anticipate additional trainings taking place at Healthy Baby Network to work with different communities. We're also actively getting our curriculum translated into different languages based on some of the work we're doing in New Jersey, because they're quite diverse as well. So those are both, stay tuned, and thank you for the recommendation. Even though you didn't make it to talk to RIT around working with the deaf community, you kind of did. Thank you, Susan.
And the last question that I do have right now is, how do we foster the interprofessional teams to best meet the needs of the patient?
That's a really good question too. So I think with that, really having some of the pre-work that has happened in this project with Healthy Baby Network and FLIPS, that's been a vitally important part of that interprofessional team work. But that's a handful of doulas, right? This isn't going to slow down. There's going to continually be new doulas that are coming into the landscape and are going to be working with the different hospital systems and different teams across the hospital system. I think that I don't know if this is something that's in place, but having a plan or a way of working is something that I believe will likely emerge. Hasn't emerged yet, but I believe that it will emerge. How best to communicate, and I think it's going to vary too, based on obviously the patient and the doula. But the first and most important thing is to be open, right? And to not throw a wall up as soon as there's another person in the milieu, because that will immediately put that birthing person at risk. I don't have any other way to describe it or to explain it. So being open to partnering and working with this doula, recognizing that in many instances, these doulas have decades of experience in supporting birthing people, and they are an asset to your team, right? So that's the first part of that. I think something that will have to happen between hospital systems and Healthy Baby Network, or hospital systems in different doula groups, is knowing what that actually looks like for you. If throughout that whole process, you remain open, right? And don't throw up barriers, especially unnecessary barriers for the doulas, then I think you'll be in a good position. I don't have a perfect solution to that. I think it's going to vary based on the different providers, but I'm happy to talk more about that if you want to connect. And my email address is right there.
Thank you. Our next question, the person says, thank you, Dr. Dillian. And the question is, why is it that affluent Black women have higher chances of dying or experiencing more complications during birth than low-income Black women?
It's a really good question, and there's so many pieces to it, right? So one thing that is probably anecdotal, but I don't think it's that anecdotal, is in a lot of instances, affluent Black women maybe are coming to have their babies a little bit later, right? Because it takes a while to get to that point. They're getting a lot more education. So it's those two things: more affluent, higher education, more time in their career. So that's an added piece of it. I think there's also more exposure to racism, which can be very traumatizing and actually shortens our life expectancy. It's all of this, it's true. I can give you facts. So all of those things are interfering with how our bodies work, right? So I think many of you have probably seen the study around telomeres, right? What we're made up of, they're shortened when you're exposed to more racism and the trauma of racism. That's going to negatively impact your birth. So if you're navigating places and spaces where no one looks like you, spoken as someone who's done that, right? Navigating spaces and places where you're the only Black person, and every time anything about Black people is discussed, you feel the wind as everybody looks at you because you must be the expert in everything that's ever happened to Black people. That's hard. I can tell you now, that's hard. You expect that to happen. So all of that to say that that is more of this internalized racism, this trauma that happens associated with racism, and that's shortening your telomeres, whether you like it or not, that's happening. And then you get pregnant. And maybe you're 42 when you have your baby, that was me. You're at risk. You're in a lot of risk, especially if you're in a hospital system that's associated with where you live, right? You're more affluent. You live in an area where the hospital system is mostly white folks. They don't see you all the time, right? There's a lot here. And if you're looking at it from a national perspective, which is where the data comes from, that's even more extreme in other communities than one that we live in, right? So in terms of going into a hospital system where no one looks like you. So there's a lot of pieces to it. There's not one reason, there's several reasons. But a lot of it, again, comes down to the racism that we experience over our lifetimes and what we're experiencing interpersonally while we're going through that experience of having our babies.
Thank you. The other question I have is, do you know if we have abortion doulas or abortion doula training in Rochester?
So abortion doula training, we do not have that in Rochester. I anticipate that coming at some point. It's something that we've definitely talked about at Health Connect One. We're in this sphere of reproductive justice. And we definitely want people to have bodily autonomy. So that's something that we definitely have discussed. It may not be us that does it. I know that there are other organizations that do that type of training, but I do anticipate it coming to Rochester. And then I think too, for a lot of folks who have had miscarriages and then have to have, like a D&C or a different experience like that, having someone there with them, right? I could see the training, including miscarriage and abortion, having someone to provide that support is vitally important. And yes, Randall, you were right. It's affluent Black. I'm reading the chat. But yeah, so definitely having that training, you'll hear about it. I'll make sure that the U of R gets information if that does come to town. And yeah, Randall said it was low-income white women. So yes, affluent Black women have higher mortality that's pregnancy related than low-income white women. And it's both too, yeah.
And the other question I have is, they first want to acknowledge, forgive their ignorance as a non-medical professional. Is there any crossover between services provided by doulas and midwives, or are they completely separate? For example, if different, are there community-based midwives, or are there, or is there a need for them?
So it depends on the community that you're in. I think here midwifery is largely associated with hospital systems. It's not something that we necessarily have rooted in community, although some midwives may describe themselves as such, especially if they're in a practice that is more community-based. But as far as like a lot of direct entry midwives, you're not going to really see that here. Doulas and midwives are complementary. So doulas do nothing clinical. So you won't see a doula checking to see if someone's cervix is dilated. They're not going to do anything clinical. What you may see them doing is helping someone to get into a more comfortable position for labor, right? Walking with them. I remember my doula walked with my husband and I, and we talked about Marvel. He's a comic book geek. So we talked and talked and talked. And every time I had a contraction, we stopped. And then he would continue. But they do all sorts of comfort measures type things, and they can get you referred to services that you may need, right? So if they're recognizing that maybe you're feeling a little bit low postpartum, or even during your pregnancy, they can get you support for mental health. Like, they don't do the same things. I think you could get some of those referrals as well from midwifery. The difference as well is the amount of time spent, right? So a doula spends a lot of time with the people that they serve, especially if they're working in community where the needs may be greater, right? That's intentional. Our model is one where we want you to spend a lot of time with the folks you're serving, because if you spend a lot of time with the folks you're serving, they become more comfortable with you, right? They're going to be able to share things that maybe they didn't feel comfortable sharing at first, maybe things they don't feel comfortable sharing with their clinical providers, right? So we do encourage them to spend a lot more time. That's one of the biggest distinctions between them, besides the fact that a doula is non-clinical. Like, there's nothing clinical about that role. It's a social, emotional, and educational support.
Thank you. And another question that I actually want to ask you is, do you anticipate there being a birthing center to really help capture the more community-based births?
That's a great question. So I anticipate it at some point. I don't know when that's going to happen. I would love to see it. I don't know. This doesn't typically happen. It just doesn't typically happen where hospital systems and birth centers play nicely together. I would love for that to happen here. I would love for Rochester to be an anomaly in that way, and do something that is really in service to the community, right? Like there are people who are low risk and would benefit from having a home base in their community where they're also able to have their babies. So I do anticipate it. I don't know how soon it's going to happen. I think it's going to take a lot of time. It takes a lot of time to open a birth center anywhere. But I think here with the two hospital systems and, it's going to take a while, but I do anticipate it at some point.
And one just popped in. It says, could prenatal genetic counselors play a helpful role in birth equity?
Yes. And I have a quick story. So when I was pregnant with Lily, I had to have an second ultrasound while I was on vacation. So I was in Texas and I was like, what's this going to be like? Because I'd never had to have any kind of medical care outside of New York State. So I had this ultrasound and my baby had a short nose bridge, right? So her nose bridge was a little short and I'm older and we had a whole bunch of other things that had happened before that. I won't bore you with all the details. And they were like, okay, well, that could be a marker for some sort of genetic issue. So I had a second genetic test because the first one picked up on her twin that didn't make it, which was a boy. So I was like, we're going to do everything again. So we did the genetic test again. And when I went in and talked to the genetic counselor said to me that it's not uncommon, and this was in Texas, it's not uncommon in the Black and African-American community for that nose bridge to be a little bit shorter. But nobody said that to me in New York State. So I think that maybe they're just more comfortable. Maybe they saw a different population and that had come up repeatedly. I think information, this is my point, information is power, right? So having that information and having genetic counselors, birth supports, anybody who's working in birth, right, be comfortable talking about race. That's a huge leap. I think that there's a discomfort in talking about the fact, something so basic that, well, your nose bridge is short, Twyla, your baby's nose bridge is short, y'all both Black. Like having that conversation is something that's so simple, but can make a really big difference because I instantly felt more comfortable with that person. Instantly. So anyone who is in contact with a birthing person or family, they can have a helpful role in birth equity. So anyone who's involved at all, anywhere, can have a helpful role in it. I hope that helps. I like little stories. You probably noticed.
And I don't seem to have any more questions in the chat. Thank you for explaining.
No worries.
Oh, wait, I got one more. Sorry.
Okay.
It says, in thinking about culturally congruent community care more broadly than around pregnancy, birth. Oh, wait, birth type and stuff. I could imagine that chronic disease doulas might serve a similar role. Do you know of any programs like this?
Great question. This is going to emerge. So it's a community health worker, right? So that's the best way to describe it. A doula is a community health worker. So when you have people who do diabetic education, they're a community health worker, right? So some of this exists already. It's just called differently. Something that's very interesting that is emerging is an end of life doula, right? So this is someone who's working in hospice or working with a family who's losing someone. Like they're working with the person and with the family. And it's an incredible role. I couldn't do that role. I'm more geared for the beginning of life, but it's a very important role. And I do anticipate like some of the things that we've learned from doulas and how they work and this cultural congruence. I envision that going into other categories, right? So the value and the research that we're now doing a lot more of at Health Connect One and other organizations, I envision that and the best practices that go along with that really in a good way getting, woven in to other community health worker systems that exist.
And then another question just came in. That would be amazing. End of life doula. How would that differ from hospice volunteers?
There's probably, again, because those volunteers are also kind of like community health workers, right? Like we have so many different wonderful, beautiful community health workers. It's a very important job, under-recognized, very important job. It would differ in that they would have more training and expertise in, and maybe not, but it would differ in that they'd be trained specifically to work with people on navigating the end of life, just like the doulas help them navigate the beginning of life, right? And comfort, right? They're not going to give medication, but there are things that they can support families with, referrals to different entities, a lot of the things that are related to social determinants of health. They're really more in that lane, and I'm not overly familiar with all the different things that they do, but it's definitely something. Yep, that doulas for dying. Yep. There you go. There's your answer right there. Doulas for the dying started in New York City by women who had been involved with birthing doulas. So it's a direct outgrowth. So the same kind of thing, but for the end of life, right? I would imagine that there are definitely comfort measures and working with the families similarly to how doulas that work at the beginning of life or birth doulas function. Thank you, Nana, for that. Anyone else? No? Okay. Well, you all have my contact information, and I hope I do get some emails because, you know, my presentation was a combination of so many things. So there likely will be other questions that emerge. If there's a need for information, flyers, rat cards, tips on how to get folks hooked up with doulas, don't hesitate to reach out. I can point you in the right direction and get you some materials.
Once again, thank you, Dr. Dillian, for your time spent with us today. I would like to remind everyone to join us on Monday as we debrief this talk with Dr. Tracy Terrence. If you've not already done so, please sign up for the Equity Challenge at URMC Celebrates to receive daily challenges to your inbox. Next Friday, we will hear from Vice President of the Rochester Board of Education, Beatrice LeBron, as she talks about healthy schools and nurturing healthy youth in our community. Thank you, everyone. Enjoy your day and happy Black History Month.